side in this session. I would like to introduce and call upon the stage the second speaker, Professor Jan-Steffen Krüssel. And I've always learned that less is more, but I guess more is less also. So Professor Jan-Steffen Krüssel completed his medical studies already a while ago. I'll do it
Thank
that. You're very welcome. Okay, we'll go to the more recent things then. So he's a member of the board of directors of the German IVF-Registry and a member of the scientific advisory board of the German Chamber of Physicians. So I think he's the perfect person to discuss the paradox of DET versus SET. Professor Jan-Steffen, the floor is yours.
Thank you, Mrs. Chair, for this very kind introduction. I have no financial conflict of interest, but I must admit that I had a potential conflict of interest that was related to the UEFA Championship, because I live in Düsseldorf, very close to the Netherlands border and to the German border. And I also love the Netherlands because I travel to a small house by the sea very often, and my prediction initially was that Germany would play the Netherlands in the UEFA final, but this would have led to a conflict of interest because I would have to decide who to cheer for. Thanks to the Spanish, this conflict of interest has never occurred. Well, yes, thank you. And there were also some Spanish colleagues who apologized already. Well, let me briefly introduce now the German IVF Registry. This was founded in 1982, and the initial group consisted of 5 university-based centers, and it is completely voluntary. We are not. We don't have to obey a law. It's our own intrinsic motivation to collect the data, to report the data, and to make them public. And we even pay for this. We pay €2.20 for each cycle that we collect in the German IVF registry. Still, we have 140 centers participating, almost all centers in Germany. And one thing that is special about the registry is that in 1997, we implemented the electronic data collection and we implemented the prospectivity. And you probably do not know what this means. It means that we have to start entering the data of the cycle before we know ourselves how this cycle ends. And in other words, it means that cheating has become almost impossible. Yeah, we're very proud of this. We have now an overview on almost 2.4 million cycles, and we know that through the work that we do as clinicians and biologists every day, almost 400,000 children are born after IVF, ICSI, and cryo in Germany, and we report this data publicly. And since a few years, we do this also in English for everybody who wants to scan this QR code. You can download the reports there. And the ESHRE has chosen Germany and the German IVF Registry as one of the pilot countries for the EUMAR project. So this was the advertisement. Now to the data. From the German IVF Registry, we know that the situation is getting better in Germany. From the European IVF Monitoring Consortium, we know that there are still some countries in Germany where transfer of 3 or even 4 embryos is taking place. In Germany, the average number of embryos is declining. It is now 1.56 in fresh cycles, but still 15.5% are multiple births that result from these transfers. Although we know that, this is also data from the German IVF Registry, that from the 14.4, that only 14.4% of twins are delivered at term, 85% are preterm deliveries. And if you look at the triplets, it's even more severe. 100% of the triplets are preterm, and almost half of them were born before 31 weeks of gestation, leading to the known problems with neonatal intensive care unit that we all are aware of as clinicians. So the problem that we have in counseling our patients is that the couples who undergo ART understandably want to maximize their chances of success. Everybody of us would do this. And in this situations, they often opt for a double embryo transfer, and they completely underestimate the number of multiples and the number of the risks that are associated with these multiples. The obvious solution would be to convince the couples that have more than one embryo available for transfer to opt for the single rather than the double embryo transfer, a situation that we all know when we counsel our patients. So our objective from our data was that we wanted to analyze specific treatment outcomes of women that had comparable good prognosis conditions, make it short and simple, women who have 2 blastocysts available on the day of transfer and then either receive a fresh cycle blastocyst double embryo transfer or receive a fresh cycle blastocyst single embryo transfer and a subsequent frozen thawed single embryo transfer with the second blastocyst that was cryopreserved in the fresh cycle. It is a retrospective real-world data analysis from 134 German IVF centers who collected the data in the time between January 2017 and December 2020, and we checked the pregnancy outcomes until the end of 2021. What did we define as comparable good prognosis conditions? All the patients had to be in their first ART cycle. There must have been no freeze-all cycles, and all these patients needed to have at least 2 blastocysts available on the day of fresh transfer, and we included only cycles where cryopreservation of either 2 prenuclear stages or embryos was performed, because in Germany this is not covered by the insurance company, and otherwise we would probably have had a financial bias. We could identify almost 20,000 patients who fulfilled these criteria, and this is the summary of the results. Don't worry, I will show you the important things in detail, but these are the patients who opted for the fresh double embryo transfer, and one of the gratifying results that we immediately saw was in this situation more patients already opt to have a single embryo transfer and freezing of the second blastocysts. These are the women who have already received the second transfer of the frozen thawed embryo blastocyst, and as you see, not all of these patients have received their second embryo. This is because many of them got pregnant and then wait still for the sibling. But this on the very right side is the assumption that all these embryos would have been transferred with the same results that we have in the third column. Well, what we found, and this is very, very helpful, as I think, in counseling patients, is first of all, no surprise, the clinical pregnancy rate and live birth rate is higher after double embryo than after single embryo transfer. Everybody would have been surprised if this would not be the case. But the difference is not as high as you probably would think. The clinical pregnancy rate is only 7 percentage points higher, and the live birth rate is only 5.4 percentage points higher in the double embryo transfer group. But the patients who only had a single embryo transfer still have a chance for the second embryo, and the clinical pregnancy rate after this frozen thawed embryo transfer was almost 30% with almost 20% live birth rate. And what we looked also at in detail is the multiples resulting from these 2 transfer regimes. There were 20 times more multiple births after double embryo than after single embryo transfer, and after double embryo transfer we had 1,180 twin births, 30 triplet births, and even 1 quadruplet birth, because both of these embryos cleaved into monozygotic twins. After single embryo transfer, we still had some multiples, but only 89 in total, and there were only twins, no triplets, no quadruplets. And if you look at it from another way, almost 50% of the children that are born after double embryo transfer are multiples. And if this is not enough to convince the patients, we even calculated the assumption that 1,000 women who have 2 blastocysts on the day of transfer and then have a double embryo transfer will have 514 children in the end, and the other group having 2 single embryo transfers will have 536 children. This can clearly be shown from the data, and this explains the title of the talk, The Paradox of Choice in Double Embryo versus Single Embryo Transfer. More is less. I mean, more embryos for transfer in the end is less children born. So the clear winner is, as you see, the single embryo transfer. And this helps us now to convince our patients in this situation. Especially the good prognosis patients do not benefit from a double embryo transfer. And this also reflects in the motto of the German IVF Registry. For us, success is the creation of a singleton pregnancy with a healthy mother and a healthy child. This is our motto, and I want to thank all the participating centers, all my colleagues from the board of directors, and thank you for your kind attention. Thanks.
Okay, thank you very much for your talk. If there is a question, please come to the microphone and state your affiliation. In the meantime, I also have a conflict of interest to declare.
You're Belgium.
Yeah, so we were also kicked out of
yes.
the tournament, unfortunately. But I do feel some competition, though, because we were also selected as a country for the EHSRE registry. Yay! So we'll meet each other there.
We'll meet there, yes.
Anyway, my question is the following. Very nice data. We did the same thing with our registry, and we ended up with a 17 times higher chance of having twins, actually. Yes. So what is your idea? How are we going to... Do we need to make this obligatory? Do we need to say SET, one blastocyst, one blastocyst for everyone, all over the world? Or how do you think this is going to be practiced? Because we all know this.
Yes.
And still, a lot of centers don't do that.
Yeah, I know. And we are, since many years, we are trying to present, or not we try, we present these data on every meeting in Germany. We meet once a year. And I think this is one of the reasons why the number of embryos is really declining over the years. Mm-hmm. I'm not a fan of something that has to always to be regulated by laws. I'm more liberal, and I think it's more effective to convince with data and not to set up a rule for everybody.
Okay, thank you. Yes, the gentleman over there.
Hi, Niels Lambert from Amsterdam. Actually, it's in line with the comment you just made, the chair of the meeting. I mean, apparently we, first of all, haven't been able to convince all doctors in Germany.
Yes.
And second, you are not, well, maybe not, I don't mean it unpolite, but reluctant to convince the patients. I mean, why should you, as a doctor, apply and comply with a request of a patient that she wants two embryo, or the couple wants two embryo transferred? You can just say no, you're going to get one, and another next time another one. This is the way we do it.
Yeah.
I mean, we are doctors and we try to treat people and do not want to harm.
Yep.
So I think you don't even need legislation. You need common sense from the doctor in the relationship with the patient.
Yeah, you're absolutely right. And I don't know the English translation, but there's a saying in Germany, Sie rennen eine offene Tür ein. You run through an open door. Because I'm very proud that in my center, I can now say we have, since 1 year, we only had single embryo transfers. And this is even more remarkable since in Germany we have this law, this embryo protection law, that does not allow us to routinely do elective single embryo transfers. We are not allowed to generally create supernumerous viable embryos, which makes it even more difficult. But I try to be an example and create an example for my colleagues also, and I think this is something that is effectively seen, not only me, there are many others in the DER community who do the same. And I absolutely agree. We have to convince with arguments and with data, and then it will, at one point, it will work.
Or provide a guideline according to which all your colleagues should act. Anyway.
Thank you, Niels.
We don't need to convince you.
Thank you very much. Yes, please, go ahead.
Cindy Farquhar, I'm the clinical director of a clinic in New Zealand, and I'd just like to say, with your approach, it doesn't seem to be working. I think I might be echoing what Professor Lambert just said, and I don't want to go. But in particular, your data, I didn't see the proportion of babies that were multiples still. You had the raw numbers, but not the percentages. And that would be helpful, I think, to see. We went through this in 2005. Our government funded us to do single embryo transfer. They said, we'll give you extra cycle if you'll do a single embryo transfer. And we haven't, we've had a 99% single embryo transfer across, and the same in Australia. I mean, the numbers are down in the single digits, less than 5%. I don't see the percentages of babies there.
Yeah, it's...
you've put it the other way around.
Yes.
And I feel you need
second,
to
I will show
actually...
It's very difficult to see.
Oh, well,
but,
sorry, I'm sorry, you can't expect someone this old to read.
Sorry, but I would like you to encourage you to download the paper.
You.
There you
I will. And I'd like to encourage you to, do guidelines or get it done, because the difference it makes, I'm in a single system with a neonatal unit, and the neonatal units were extremely happy with us when we stopped this.
Thank you very much. I will take one last question. I'm very sorry, but the gentleman in the room was first, and we only have time for one more. Please, go ahead.
Thank you very much. I'm Sushil Vani from Glasgow in Scotland. This is as convincing as it can get for good prognosis patients. Do you have any data where the equation starts to shift from single to maybe double for more poorer prognosis patients?
Not in this detail so far, but this is something that we have on our bucket list. We are going to look at this poorer prognosis patients. The reason that we wanted to do it, to start with the good prognosis patients, was that we thought that the risk for multiples is highest in this group, and also we could easily set up comparable conditions in this group, easier than in poor prognosis, which is a more heterogeneous group. But point is taken, and we look into this.
Thank you.
Okay, thank you very much. So the message is easy: single embryo transfer for everyone, all over the world, no matter how young or old you are, that's it. So let's get over it.